So we are live in 3, 2, 1. We start. So we are live.
Good evening, everyone. It's a great pleasure to welcome you all for today's webinar, Oncology Update, Lung Cancer Perspective. I would like to invite Dr. Abhishek Pathak, sir. Sir is a consultant medical oncologist, Eastern Command Hospital, for giving a welcome note. Please start, sir.
Thank you, Gariba. Thank you. And thank you, organizers, for giving me this wonderful opportunity. I think in today's era where so many things, newer things are coming up every day, I think for a general medical oncologist, as we are now called, who are looking after all types of cancer, I think there is no better way to keep ourselves abreast than these, continuing medical education, the CMEs that you all keep on holding. So today we have a very, very good lineup of eminent speakers in the field of oncology and, dedicated more towards the management of lung cancer patients. So without wasting much time, I'll request Dr. Pinat sir, who is a very senior consultant radiologist, to give us perspective about EBUS and, how it has come up in such a big way. And in fact, it's becoming much more simpler way, and probably a time would come when procedures like mediastinoscopy, which till now is the gold standard, but maybe EBUS and the newer techniques would actually replace it. So so very good evening, sir, and we are just waiting to be enlightened by the talk you are supposed to give us. So over to you, sir.
Can I share my screen, please?
Sure, sir. You can share.
Yeah. Is it seen now?
No, sir, it's not visible.
Okay. Yeah, is it?
Yeah, sir. Is it visible? Can you please make a full screen?
Yeah, I'll do that. It's okay now?
Yeah, sir.
Yeah. Yeah, thank you, everybody. At the outset, I must say I'm just recuperating from an acute viral prodrome, so I'm having a bad cough. So please pardon me for intermittent disturbances that I might cause. So I'll be speaking on mediastinal lymph node staging, the role of EBUS. So before going into the subject, let me just recapitulate a few of the highlights of the 8th edition of the TNM classification of lung cancer. The red ones are the ones which are changed from the 7th edition. So as we are considering EBUS, will not be concentrating in the AM disease, because AM disease, when there is a confirmed AM disease, it is outside the scope of EBUS. So the T1, T2, T3, and T4 are up to 3 centimeter, 3 to 5 centimeter, 5 to 7 centimeter, and more than 7 centimeter lesions, along with a few other things which is known to almost everybody, I'm sure, who are listening here. The N1, N2, and N3 lymph nodes, they need a bit of elaboration, so I'll do that. So these are the mediastinal lymph nodes that we see. The level 1 lymph nodes are the ones which are at the level of the clavicles and up to the superior margin of the manubrium sternum. And the level 2 lymph nodes are 2R and 2L, to right and left, are the paratracheal, upper mediastinal paratracheal lymph nodes. The level 3 are level 3A and level 3P. A is the prevascular and level 3P are the prevertebral or posterior to the esophagus. The level 4 nodes are the right and left lower mediastinal lymph nodes. The level 5 are lymph nodes are the aortopulmonary or lateral to the fissure for ligamentum arteriosum, and level 6 nodes are the pre-aortic nodes. Level 7 are the carinal nodes. 8 and 9 are the lower mediastinal nodes. 8 is periesophageal node and 9 is in the pulmonary ligament. And 10 to 14 are the intrapulmonary nodes starting from hilum up to the lung. So why it is important? Because when we do staging, we need to know if there are enlarged lymph nodes in these groups, and if they're enlarged, how probable is it that they are malignant, and if it is probable or if it is doubtful, how to clinch the subject whether it is malignant. So for a right-sided lung cancer, the N1 nodes are the nodes from 10 to 14, level 10 to level 14 nodes. The N2 nodes are the 8, 9, and 7 nodes, and the 4R and 2R nodes. The level 1 nodes are N3 nodes. That is, N3 again is outside the purview of EBUS. When there is N3, because there is no surgical, the treatment possibly is non-surgical. So EBUS and the endoscopic ultrasound are not of much use in these cases. And all the ones that are shown in yellow are the N3 nodes for right-sided lung cancer. Now, when we say how to differentiate between a level 4 node and 10 node? In the right side, it is the lower border of the azygous vein, which above that are the 4R nodes and below are the 10 nodes. In the left side, it is the upper margin of the pulmonary artery, which differentiates 4L from level 10 nodes. Is it clear? Now, so when we have all the details of the tumor size and the nodal status, then the staging is done from stage 1A through stage 4B. And in the right, in this table, we have the stages in which you have the role of EBUS or endoscopic ultrasound. So it is recommended for up to stage 3A tumor. So in T4N1 is the highest as far as the tumor size is concerned, and the T2B N2 is as far as the nodal status is concerned. So anything beyond this, we don't, the EBUS is not recommended. So to understand this, we have to know a little bit of the treatment planning. I'm sure you all know it better than me, but there is no harm in recapitulation. So if there is no enlarged lymph nodes and there is a peripheral tumor, no further investigation is required. If the PET-CT is negative, then patient directly goes for surgery. And then adjuvant chemotherapy is given as subsequently. If there is no enlarged N2 nodes, but there is a central tumor or hilar lymph nodes, and or there is nodes. So if there is no N1 nodes, patient again is fit for surgery. If there are N2 nodes, patient and the nodes are potentially resectable, then there is a multidisciplinary assessment is done, and the patients are given benefit of the benefit of doubt, and patient can have surgery or they go to multidisciplinary treatment. If there are N3 nodes, there is no scope of surgery, patients directly go to multidisciplinary treatment. And if there is extensive mediastinal N2 nodes, again, it's not required to investigate by EBUS. So these are the recommendations in which all cases we need to do EBUS or invasive mediastinal diagnosis for nodal status. So if there is a peripheral 1A tumor and there is no lymph node, then nothing is required. Patient can directly be posted for surgery. But if the tumor size is less than, if the tumor is solid and less than 1 centimeter, and tumor is non-solid less than 3 centimeter, the role of EBUS is optional. In central tumors, like if you refer to that table before, in central tumors, T1, A, B, C, all T1 tumors with no nodes. But if it is central, if it is T2A with no nodes, if it is T2AB, T1 ABC with or T2AB with N1 nodes, or T2B with no nodes and T3 with no nodes, again it is recommended. In 3A stage 3A disease, or which are T1 with N2, T3 with N1, and T4 with N0, it is recommended to do EBUS or invasive mediastinal diagnosis. The other recommendations are, when we choose which one to be done, the least invasive biopsy is preferred, and evaluation of the subcarinal and contralateral lymph nodes is important even when employing EBUS or US. This is very important to understand, because if there is a contralateral lymph node, immediately it comes to N2. And when we get a patient with a disease, we should biopsy after the diagnosis, we should biopsy the node or the organ which brings it to the highest grading. So if a patient has a lung malignancy with a distant metastasis, if we biopsy the metastatic lesion and find there is malignancy metastasis there, then definitely the patient goes to stage 4 disease. So it's very important to understand this philosophy, because when we are doing endoscopic ultrasound or endobronchial ultrasound, then we should attempt to take samples from lymph nodes which will take the disease to the highest level or highest stage. So there are 3 examples here. A 50-year-old female presented with an headache and chronic non-productive cough. The CT showed a lesion in the right anterior aspect with a large mediastinal lymph node, and the CT scan brain showed a big lesion in the occipital area in the right side. So it is and the biopsy from the lesion yielded adenocarcinoma. So immediately we know it is a stage 4 disease, and we don't need to do anything. So it is not recommended to do an invasive mediastinal lymph node staging in this case. In the second scenario, we have a 3.5 centimeter mass. So it is a T2 lesion, and there are sub-centimeter level 4 lymph nodes. So, and the transbronchial biopsy yielded adenocarcinoma. So if this lymph node, which is small on CT and has no definite characteristics to be coined as malignancy, even if it is there, the CT is never the sensitivity and specificity of CT is not very high as far as the lymph node characterization is concerned. So this patient will definitely need an invasive mediastinal assay to stage the mediastinal disease. And in third scenario, there is a small lesion in the right right lung with no discernible mediastinal lymph node. So this is a T1 disease with N0. So definitely the patient can go directly to surgery, provided the transbronchial lung biopsy yields malignancy. Here it yielded adenocarcinoma. So in the first, it is not required to do an invasive mediastinal lymph node staging. In the second case, it is recommended to do EBUS or TBNA and subsequently other tests like mediastinoscopy. And in third case, again, EBUS or TBNA is not recommended. Now, coming to the role of imaging, conventional imaging in mediastinal staging, we have the conventional imaging like the CT and the PET-CT. We have endoscopy and we have surgical procedures. So the ideal test is one which is available and in which we have expertise, which will yield tissue diagnosis, which has a high accuracy, which is safe and has low cost. So CT and PET-CT are very important, armamentarium, even though they cannot always characterize the lesion. A preliminary CT is done in all the cases. A PET-CT should be done in all the cases because it is a very good baseline and helps us to follow the patient up subsequently. The endoscopy, we have conventional transbronchial endoscopy, transbronchial needle aspiration, and then endoscopic ultrasound with FNA. And then in the more invasive procedures are mediastinoscopy, VATS, VAMLA, and TEMLA, and anterior mediastinostomy. So coming to CT, by what we do is when we get a lymph node which has a short axis diameter of more than 1 centimeter, we think that it is significant. We take it to be significant, and less than 1 centimeter lymph nodes we generally tend to ignore. But in all these patients need to have a PET CT, and in PET CT, if the SUV or the SUV is less than 2.5, it is less likely to be malignant. It can occur in inflammatory conditions, sarcoidosis, tuberculosis, etc. And if the lymph node size is less than 10 centimeter, then also PET CT is less sensitive. The sensitivity of CT is 51% versus PET CT, which is 74%, specificity almost equivalent. So as PET CT is superior to CT as far as mediastinal staging is concerned, it is recommended that all patients having a malignancy of the lung should have a PET CT to assess the mediastinal status and also the distant areas where it can metastasize. And PET CT increases the sensitivity of diagnosis in lymph nodes which are 10 to 15 millimeter or more than 15 millimeter. A negative PET CT versus only CT, the chances of malignancy is quite high in CT, but in PET CT, it brings down the specificity to a very low level. The false positive results in PET CT is about 15 to 20%, and false negative is 13 to 25%, which is quite high. And the false negative occurs in suspected N1 nodes, discrete mediastinal lymph nodes, a tumor size which is more than 3 centimeter, and if the nodes are negative, the central tumor where the proximal 1/3 of the hemothorax is involved, or in primary tumors which has a very low SUV uptake of the primary tumor, the PET CT for nodes can also be negative, and where we are considering SBRT treatment. So in all these patients, up to stage 3A, it is recommended to do a invasive mediastinal staging, and the mode selected is, as I said, depends on the availability and the expertise. So why endoscopic ultrasound or endobronchial ultrasound? Endobronchial ultrasound has got some limitations. It has a sensitivity of 78% and a false negative rate of 28% in N2 disease. But it is real-time imaging. It's an outpatient procedure. There is no general anesthesia. There is no scar. There is no need to stop. And it is fast and safe. And the sensitivity and specificity and the accuracy of EVAS and TVNA is pretty high in reported series which are done long back, and with increasing expertise and increasing and better instruments, that they're only expected to go up. So the factors that affect the diagnostic yield are the sampling, then micrometastasis, especially in nodes which are less than 5 millimeter in size, and if the nodes are inaccessible. So inaccessibility is definitely a problem. Therefore, we have to, we have to complement by other tests like 8 and 9, level 8 and 9 nodes are not accessible by EVAS. So you have to take the endoscopic ultrasound or combined ultrasound study to evaluate the level 8 and 9 nodes. So the EVAS TVNA can evaluate the level 2, level 3, level 4, level 7, and 10 to 12 nodes, intrapulmonary nodes. Whereas the endoscopic ultrasound can evaluate the 4L, 5, 7, 8, and 9 nodes. And it can also evaluate the left adrenal gland, the left lobe of liver, and the celiac axis lymph nodes. And in mediastinoscopy, we can see all these nodes that namely the 2, 3, which is not seen by EUS, the level 5, 6 nodes which are not seen by EUS, this and the level 10 nodes. So when the accessible, it's a question of accessibility. If you are targeting a particular set of lymph node, that also can say that which modality is to be taken. So this pictorially evaluates which are the nodes evaluated by endobronchial ultrasound and which are evaluated by endoesophageal EUS or endoscopic ultrasound. The level 10 to 12 nodes are evaluated only by endobronchial ultrasound. The level 2 and level 4 and level 7 nodes are evaluated by both endoscopic and endobronchial ultrasound, and level 8 and 9 nodes, which are not so common, are evaluated only by endoscopic ultrasound, and along with liver metastasis, celiac lymph nodes, and adrenal glands, which can be seen by endoscopic ultrasound. So when we combine endobronchial and endoscopic ultrasound, it is called combined ultrasonography, and it is seen that combined in various studies that combined ultrasonography increases the sensitivity and the negative predictive value of our tests. So a positive endoscopic ultrasound FNA in lymph node, which could be assessed by EBUS and TBNA, and station 8 and 9 nodes, there is no difference in diagnostic yield because both of them come in N1 and N2. For same side, it is N1, and for opposite side is N2. And there is very low prevalence of lymph node stations 8 and 9 in lung malignancy. False negative EBS and EUS. The negative results from EBS and EUS should further be investigated by mediastinoscopy. Like in malignancy, say if there is associated pleural effusion and pericardial effusion, and if the aspirate is negative for malignant cell, it has to be repeated. Similarly, when we are doing EBUS or EUS and the samples are negative for malignancy, it should be complemented by mediastinoscopy because it is of paramount importance to tell the patient the prognosis and to select the surgical option. So this is very important to understand that if EBUS and EUS, which has a false negative rate of about 28%, which is quite high, should be complemented by a mediastinoscopy. So what are the surgical options available? We have mediastinoscopy, we have anterior mediastinostomy, we have extended mediastinoscopy, then video-assisted mediastinal lymph node aspiration and trans-cervical extended mediastinal lymph aspirations. And the various lymph node stations that can be evaluated by these procedures are illustrated here. And the sensitivity and specificity of all these tests are acceptably good. Therefore, according to the need and the location of the lymph nodes, it should be selected. Of course, the expertise should be there. So combined ultrasound and mediastinoscopy is done in patients, in populations with a very high prevalence of mediastinal lymph node metastasis. Combined ultrasound, if it is negative, it should be complemented by mediastinoscopy, which increases the sensitivity than mediastinoscopy alone. Adding mediastinoscopy to combined ultrasound increases the sensitivity and negative predictive value of staging by 9 and 11% respectively. So invasive mediastinal imaging, the goal is to avoid surgery on positive N2 disease. If the tumor size is more than 3 centimeters, if the tumor is central in location, if there is a N1 or discrete mediastinal lymph nodes, in N1 or N2 lymph nodes, positive on PET-CT, and negative PET in low SUV uptake in primary tumor. But it is not required in patients with T1 disease with no lymph nodes, with if the tumor is peripheral. In central tumor, it is again recommended to do a endobronchial ultrasound and TBNA subsequently if it is required.
Oh, sir, brilliant presentation, but you need to conclude, sir, with a couple
Yeah,
of points.
I'm just left with 1 or 2 slides.
Yeah.
So in this case, I've already said that you need to do a mediastinoscopy. So the flow chart is if the mediastinal lymph node is negative in CT and PET, and the tumor is peripheral, patient directly goes for surgery. If it is central tumor or the tumor size is more than 3 centimeter, you do an EBUS, and if the mediastinal lymph node is negative, it goes for surgery. If the tumor mediastinal lymph nodes are positive, and you do a EBUS and US, if the mediastinal lymph node is positive, patient goes to multidisciplinary treatment. And if it is negative, then you do a video assisted mediastinoscopy. If it is positive, patient goes to multidisciplinary treatment again. And if it is negative, patient can go for surgery. So in conclusion, the sensitivity of various procedures, namely the invasive mediastinal staging procedures are almost the same. So the choice of the procedure should be dependent on the availability of the test, the experience of the skill of the operator, the location of the suspicious nodes, and patient factor. What is the acceptance of the patients? Thank you very much.
Thank you, sir. Wonderful presentation. In fact, a lot of our doubts got cleared up. I think there is some paucity of time, so maybe we can have the questions at the end. Dr. Upasana, are you there?
Yes, I'm there. Good evening, sir.
Hi, good evening, good evening. So I think there is some rescheduling and they want you to take the next session. And Dr. Tanmay, I think, is busy somewhere. So if you are there, I think we can start with your session.
Yeah, I had already requested to show the slides from my part. So,
Okay.
So if that can be done, I think the chemotherapy slides are being shown.
Oh, okay.
So if someone could share my slides on behalf of the technical team.
So I think Garima,
Yes,
if you can do that. Yeah.
Yes, sir. Yes, sir.
So Dr. Upasana would be speaking about the newer paradigm in treatment of resected EGFR mutated early lung cancer. I think this is another very exciting area where a lot of things are happening. So please, Dr. Upasana, you can start.
Thank you so much, sir. So good evening. And this is, as sir has rightly pointed out, so this is something which is very interesting and which has come up in the recent years. So quickly, without wasting much of all of your time, I would proceed and I would request my host to kindly change the slides. As we can see in the first slide, we know that locally advanced and localized lung cancers are a very relatively smaller proportion of cases. Lung cancer is the leading cause of cancer death, as we all know, and more than 1.7 million deaths are happening annually, and only around 30% of the cases usually present in a resectable stage at the diagnosis. Next slide, please. So outcomes in the early stage NSCLC needs to be improved, as we all know, and as an excellent presentation has already been taken up by sir. So surgery is the primary treatment for patients with early NSCLC, and adjuvant cisplatin-based chemotherapy is recommended for patients in the resectable stage 2, stage 3 NSCLC. And as we all know that the results from the large randomized trials and the meta-analysis have shown a 5-year overall survival benefit with adjuvant chemotherapy. And overall, the disease recurrence or death following surgery and adjuvant chemotherapy remains high across all disease stages. As we can see, the 5-year recurrence rate as per the staging in 1B is as high as 45%, which is really worrisome. So next slide, please. Now, based on a similar limited number of studies, the prevalence of EGFR mutations more or less appears to be same or similar across the disease stages. That is, the Asians almost have a 30 to 40% patients who have oncogenically driven mutation based on EGFR status. So the EGFR TKIs if they were available in these resectable setting, a similar proportion of patients may be able to benefit compared to the advanced setting. So with this thought process, we move on to the next slide, please. So this is the a new paradigm which we were talking of, the osimertinib as adjuvant therapy in patients with stage 1B to 3A EGFR mutation positive NSCLC after complete tumor resection, the ADAURA trial. Next slide, please. So coming on to the trial design, this was a phase 3 double-blinded study where the patients who were completely resected in the stage 1B, 2, 3A NSCLC with or without adjuvant chemotherapy were enrolled. The patients' inclusion criteria include they were more than equal to 18 years with a good performance status of 0 to 1 and confirmed primary non-squamous NSCLCs with the common mutations that we see, that is exon 19 deletions or L858R mutation. Brain imaging was recommended if it was not completed preoperatively. Complete resection with negative margin was an important inclusion criteria. And the maximum interval allowed for the patient between surgery and randomization was around 10 weeks without adjuvant therapy and up to 26 weeks if the patient have had their adjuvant chemotherapy. So stratification was done on the basis of stage, EGFR mutation status, and race, and the patients were then 1:1 randomized to osimertinib 80 mg once daily versus placebo. So the planned treatment duration was a bit long, that is 3 years, but the treatment continued until the disease record or the treatment completion schedule or discontinuation criteria when it was met. Follow-up, it was done until recurrence, week 12, 24, and then every 24 weeks to 5 years, and then annually, and after recurrence every 24 weeks for 5 years, and then yearly. So the primary endpoint which was focused here was the disease-free survival, and secondary endpoint was DFS in the overall population and DFS in the second, third, fourth, and 5 year. Overall survival, safety, and health-related quality of life were also taken into consideration. Next slide, please. So again, we've already discussed the inclusion criteria. So where we see the patients who have had a delay in the starting of the osimertinib, if it was more than 10 weeks or more than 26 weeks post chemo, they were excluded. And other patients who have had prior treatment with radiotherapy or preoperative chemotherapy or any other EGFR TKIs were also excluded. So next slide, please. The baseline characteristics were seen to be similar with respect to the age, sex, smoking status, race, the performance status, the brain imaging and randomization, the staging and the histology, and the EGFR mutation status, along with the patients who were enrolled for chemotherapy. All of them were similar in the osimertinib versus placebo group. Next slide, please. So coming on to the results part, as we can see, these Kaplan-Meier curves, these are wide apart, both in the primary population and overall population. So osimertinib improved DFS versus placebo in resected EGFR mutated NSCLC lung cancer, and the benefit was as high as 80% as in both the groups. And the median DFS was not reached in the osimertinib arm versus 19.6 in the placebo arm. And in the overall population as well, it was not reached versus 27.5 months in the placebo arm for the overall population, and with an excellent hazard ratio of 0.2. Next slide, please. So as we can see, there is 80% reduction in the risk of death, in the risk of disease recurrence or death with osimertinib, with a very good hazard ratio of 0.17 and 0.2. Next slide, please. So again, when the 2-year DFS was analyzed, it was seen that the osimertinib had a 2-year DFS range of around 90% versus placebo. And as we can see, in the placebo arm, the 2-year DFS is getting dropped down to as low as 32% in stage 3A. Next slide, please. Again, this forest plot also says us that whatever the criteria may be, osimertinib scored far better than the placebo group, whether it was age, sex, the smoking history, and race, or whether the stage, or whether the type of mutation, or the presence or the administration of chemotherapy. The osimertinib part scored well than the placebo group. Next slide, please. This is an early snapshot of the overall survival in patients with stage 2, stage 3A disease. And here the patients and investigator remain blinded to treatment in order to facilitate the assessment of OS at maturity, which I think would need some time to mature. So next slide, please. Now, all these trials that have had been taken place in the past have helped in coming out with a solution that we could help with the patients who are doing bad with the with the disease biology being aggressive. The EGFR TKIs in the adjuvant EGFR mutated NSCLC setting, DFS but not OS benefit have been demonstrated. As we can see, whether it is the SELECT trial, RADIANT trial, or the EVENT trial in the erlotinib drug, or whether the adjuvant CT-long 1104 or the BR.19 for the geftinib group, all of them more or less showed a DFS benefit, but none of them could establish an OS benefit in the patients who were receiving adjuvant EGFR TKI. Next slide, please. So in ADAURA, they say that they've told that the type of recurrence is a key consideration in the resected NSCLC group. So local versus distant recurrence has an impact on patient outcome post-surgery, and the preventing CNS recurrence is an area of unmet need. And the trials that have had been done in the past, that is the adjuvant RADIANT study, the most of the recurrence that were taking place, the CNS was a common site of distant recurrence. As we know that once the patient present with CNS mets, the overall survival and the comes down to a very low score, and hence osimertinib here has scored very well over other drugs, showing because of its excellent penetration, blood-brain barrier penetration, it has shown to achieve a clinically significant exposure in the brain as compared with other EGFR TKIs. Next slide, please. So again, they have highlighted the type of recurrence that has taken place in this particular trial. So 11% of the cases have mostly had a loco-regional recurrence in the patients who in the arm who were receiving osimertinib, versus in the placebo arm where the 46% patients who have had recurrence, mostly it was in form of distant mets. Next slide, please. Again, this is the same fact that has again shown us that the patients as high as 10% of cases have had CNS mets versus 1% in patients who received osimertinib. Next slide, please. So CNS recurrence is a very troublesome issue in patients who are undergoing treatment, whether in locally in advanced stage or in early stage lung cancer. So this is what has again been highlighted. Next slide, please. Next slide, please. So coming on to the safety summary, we all know that, again, along with the treatment, the maintenance of quality of life and maintenance of patient well-being is also a very important consideration that we need to keep in mind, because we are treating early resectable lung cancers. So in patients who have been randomized to receive osimertinib, the adverse events in more than equal to grade 3 were around 68 cases versus 48 in patients receiving placebo, and there were a very less number of serious adverse events. It was 9 versus 2. Next slide, please. So all causality adverse event, median duration of exposure being 22.3 months and placebo 18.4 months. So patients have in the osimertinib arm have had grade 1, grade 2 interstitial lung disease that was reported in 10 cases, that is 3% in the osimertinib arm. And the adverse event which we are all aware of, that is the QTc prolongation, was reported in 7% of the cases receiving osimertinib. Next slide, please. So again, from this trial, there was extrapolation of data for those who received chemotherapy. And again, the comparison was made of how osimertinib scored in these particular cases. So next slide, please. As we all know that overall the patient received adjuvant chemotherapy for the who had a median duration of 4 cycles, mostly being the platinum based chemotherapy for stage 2, stage 3A disease and fewer stage 1B disease. Adjuvant chemotherapy use was more frequent in patients who were less than 70 years of age group and in patient enrolled in Asia, and was not influenced by the WHO PS performance status. So next slide, please. Again, when we analyze the DFS in these patients, whether they received or not the adjuvant chemotherapy, the DFS was as high as 89% in cases who received osimertinib versus 49% with adjuvant chemotherapy. And again, without adjuvant chemotherapy, the results were similar. Next slide. DFS in patients, whether or not they received chemotherapy, remains to be again favoring osimertinib. Next slide, please. So again, here the patients who have had early stage 1B also, the patients have had a similar kind of results with osimertinib. Next slide, please. And whether it is local, also in stage 3, patients well when they were given osimertinib. Next slide, please. So again, this is the patient reported outcomes from the ADAURA trial. Next slide. So as we were discussing that the quality of life is a very important issue, and here this thing was also taken care of. A health survey was undertaken comprising of the physical component summary and the mental component summary, and there were 2 summary scores given with 8 health domains, and the patients were analyzed for their quality of life. Next slide, please. So the compliance with the SF36 health survey over time were high, both in the osimertinib arm and the placebo arm. Next slide, please. And the time to deterioration of the PCS and the MCS, the physical and the mental component summary, this result showed that they did not experience any clinically meaningful deterioration in the PCS or MCS scoring. And if the patients who have had deterioration, there were no significant difference in the time to deterioration of the scores. Next slide, please. So coming on to the summary, the adjuvant osimertinib is the first targeted agent in a global trial to show a statistically significant and clinically meaningful improvement in the DFS in the patients of resected EGFR mutated NSCLC. There was 80% reduction in the risk of the disease recurrence or death with use of osimertinib, and the DFS rates at the 2-year almost remain 90%. Adjuvant osimertinib has meaningful improvement in the CNS DFS as well as compared with placebo. And as we learned from the last few slides, the safety profile were consistent, and with the established safety profile of the osimertinib and the other TKIs reported, median duration of exposure remains 22 months. Next slide, please. So to conclude, adjuvant osimertinib will be very highly effective. It is a practice-changing treatment for the patients or the who have been resected for their early lung cancer, that is stage 1B, 2, 3A, EGFR mutated type, after complete tumor resection. And with this, I would like to conclude. Thank you. Next slide, please.
So thank you, Dr. Upasana. Very, very wonderfully brought out the advantage of using osimertinib in adjuvant setting. I think the only thing is the financial toxicity, which has to be taken.
Exactly, sir.
So, that is a very big concern. So nevertheless, the data is very good, and definitely it should be practice changing, provided the finances are of not much concern. So I would request Dr. Tanmay, is he around?
Yes, yes.
Oh,
I'm
good
okay.
evening, Dr. Tanmay. So after, some Adura trial, we get back to the basics of, cytotoxic chemotherapy, and we would like to learn new things from you. So without wasting much time, I would request you to please proceed with your session.
I am planning. Okay, can you just share? I will be sharing my slides. So are my slides visible now?
Yeah.
So is it fine? I myself,
Yes,
I
sir.
think. Okay. So, okay, good evening, everyone, and thanks for giving this opportunity for giving a talk on this role and updates in chemotherapy in lung cancer. This is what has been assigned to me. So the burden of lung cancer in India, as per the Globocon 2020 data, it's lung cancer is one of the very common cancers in India, and the number of new cases detected in both sexes runs to around 5.5%, whereas in 2020 in males, it's around 8% of the patients which are diagnosed is mostly males. So this is what is the incidence and what we see. And the cumulative risk is also around 0.61 with percentage, and the number of deaths, it's around 7.8%. The 5-year prevalence is around 5.86. So evolution of lung cancer treatment. So NSCLC was once considered as a single disease until the distinct subtypes, the characteristics were identified. So mostly the subtype characteristics are clinically relevant for treatment planning from the point of diagnosis. So initially what the traditional view was, it was simply a lung cancer. Then we came into two divisions. It was a non-small cell and a small cell lung cancer. Then came the histologic breakdown of squamous cell, non-squamous cell, large cell, adenocarcinoma, and all this. And then came the molecular pathology basics. Initially, we started with EGFR, ALK, and ROS1, and now we have the PDL1 expressions by the immunohistochemistry. And of course, and the more modern, it's the tumor mutational burden, and we don't know in future it will be some circulating tumor DNA or whatever it is on rise. So from the 90 days of 1980s, the central question was, does chemotherapy prolong survival in advanced stage? Yes, it does. What does the drugs to be used? Mostly at that time, it was cisplatin or carboplatin, what were the drugs which were available. And the remaining issues was nausea, vomiting, myelosuppression, whatever. And with respect to the best supportive care, the improvement in the median survival was around 2 to 3 months, which was seen during that time. And yes, as the time progressed, our platinum-based doublets along with the third generation agents are superior to the older doublets, like the paclitaxel, the gemcitabine, the docetaxel, the vinorelbine. So cisplatin-based regimens. Then comes the platinum doublets, which improved the median survival by 2 to 3 months more compared to the cisplatin based regimens. Then in the mid 90s, the late 90s, which of the new doublets was the best? All of them had a similar efficacy, and we saw the different regimens, carboplatin based, cisplatin based. These are the regimens. So current guidelines are for most of these early stage and the locally advanced lung cancers, mostly in stage 1. What we have is N0, no lymph nodes, observation, no proven benefit of the neoadjuvant or adjuvant setting. So in stage 1B to 2A, known N0 stage, the multidisciplinary team discusses the observation versus the adjuvant chemotherapy for high-risk patients, bronchial cut margin, if they are positive or whatever. These are the high-risk features, lymphovascular invasion. These are the high-risk features for which, but no proven benefit of neoadjuvant therapy has been seen. In stage 2B, where N1 or lymph nodes might be positive, so adjuvant chemotherapy is recommended, but no role of neoadjuvant, no proven benefit of neoadjuvant chemotherapy has been seen. And stage 3A and 3B, it's like N1 and N2 nodes, neoadjuvant chemotherapy or adjuvant or sequential chemotherapy and radiotherapy, mostly in the N2 diseases, can be seen. So these are the recommendations which we do, or which this is the planning methodology also in which we treat this at this point of time. The latest ESMO guidelines recommend that adjuvant chemotherapy can be considered in patients with stage 1B disease and a primary tumor of more than 4 centimeter due to clear-cut evidence of benefit. So what we see that primary tumor benefit, a tumor diameter of less than 4 centimeter and more than 4 centimeter. So these guidelines have reclassified that them as stage 2 in the 8th edition, and adjuvant chemotherapy may remain an option for these patients with 1B who are high risk due to other factors other than the tumor size. So chemotherapy with or without radiotherapy is the standard of care after complete resection in patients with stage 3 non-small cell. So should work up closely with the radiation oncologist in a tumor board or a multidisciplinary board. So some otherwise eligible patients may be unfit for chemotherapy due to factors such as advanced age or comorbidities or a poor performance status, but not all patients with complete prescribed course of chemotherapy. And of course, what we see that in the stage 1B or 2M MDT team consults to discuss observation versus this. And in 3A and 3B, what we said that sequential chemotherapy followed by radiotherapy may be used. So this is the latest meta-analysis for adjuvant chemotherapy, overall survival benefit from the post-operative cisplatin-based chemotherapy in early stage non-small cell lung cancer, pooled analysis of 5 trials evaluating the adjuvant cisplatin-based chemotherapy with a 4,500 patient base with cisplatin or vinorelbine, most commonly used agent, only combination shown to prolong the overall survival. And the chemotherapy has led to improved overall survival with an hazard ratio of 0.89. There is an absolute benefit of 3.9% at the end of 3 years and 5.4% at the end of 5 years with the use of adjuvant chemotherapy in this early stage non-small cell lung cancer. So impact of this adjuvant chemotherapy in early stage depends most also on the stage. And this is the retrospective analysis of estimated absolute benefit or risk for 100 patients treated with surgery and adjuvant chemotherapy based on the reported 5-year overall survival rates in the control arms in each clinical trials. So how well does neoadjuvant or induction chemotherapy work? About the same as adjuvant. The meta-analysis, there is a meta-analysis for stage 1B, 2, 3A. Neoadjuvant chemotherapy, with the use of neoadjuvant chemotherapy, the hazards ratio is around 0.87, and with the use of adjuvant chemotherapy, the hazard ratio is 0.89. So they are more or less same. So how has the paradigm changed that some antibody drug conjugates, the mechanism of action mostly binds to the target antigen, it is internalized, the payload release plus the bystander effect. This is what we see. This payload enhances the cytotoxicity, although variable drug antibody ratio affects the efficacy and the clearance. So TDX is a drug for HER2 mutated non-small cell lung cancer cohort in the Destiny Lung 01 trial. So confirmed overall response rate by investigator review is around 61.9% with CR and PR rates of around 61.9%. Only 4.8% patients had progressed and the disease control rate was around 90.5%. The median duration response was not reached with a median PFS of 14 months. So this is the NCCN guidelines, which shows that for the following regimens has been added as the neoadjuvant systemic therapy, mostly in the form of nivolumab, which we saw that 360 milligram and a platinum doublet every 3 weeks for up to 3 cycles. So platinum doublet is in the form of a paclitaxel carboplatin or a pemetrexed cisplatin. These are the regimens which we can use in neoadjuvant setting. So next, the systemic therapy regimens for neoadjuvant and adjuvant, mostly the pemetrexed and the cisplatin or a paclitaxel and the cisplatin or carboplatin. These are the chemotherapy regimens which we used either in the neoadjuvant setting or in the adjuvant setting also. Of course, the LACE meta-analysis also cisplatin plus vinorelbine is the recommended regimen, which we also saw in the LACE meta-analysis. So concurrent chemo regimens for concurrent chemo radiation, which we can use as pemetrexed plus carboplatin, or we can also use in the weekly regimen of paclitaxel weekly 45 to 50 milligram per meter square, along with an carboplatin of AUC2 with concurrent radiation every weekly. So these are the regimens which we use. And of course, if there is post chemo radiation also, there is a role of addition of immunotherapy for in stage 3 unresectable non-small cell lung cancer and no disease progression after definitive CTRT, where we use the durvalumab as a maintenance 10 mg per kg, 10 milligram per kg IV every 2 weeks or 1500 milligram every 4 weeks, up to 1 year of treatment for these patients. So novel chemotherapeutic regimens for advanced lung cancer, have we reached a play to? So these are certain agents, dataplatin, which has been shown in some recent meta-analysis, but still we don't use this at this moment of time. So novel chemotherapy regimens with immunotherapy, what we know that yes, the key as per the keynote 189, the first line pembrolizumab plus chemotherapy versus the placebo plus chemotherapy, which has shown to have benefit. And also the IM power, in which atezolizumab plus bevacizumab plus paclitaxel carboplatin has been used, and the Pacific trial, which shows that consolidation durvalumab after concurrent CTRT in 10 milligram per kg till 1 year after starting. So the future directions in non-small cell novel approaches for treatment of immune refractory non-small cell is that we use the chemotherapies which are placed over there, like paclitaxel, carboplatin, gemcitabine based, pemetrexed based. These are the chemotherapeutic regimens which we use after this. So with this, I end my talk, and I'm free for taking any questions.
Dr. Tanmay, a wonderful presentation. Very, concisely you have covered. I just wanted to know, like, do you have used this 4-drug regime as was used in Empower 150? Do you have any experience with that?
No, actually, we don't. I don't have any experience of this ABCB regimen, which we say, because we have this discussion many times in many seminars and conferences, whether they use how is the experience with. I think Bibhasda has also, if Bibhasda is in Tata, he might be having some experience about this, but if you ask me, I still don't have. But what I have heard from many people, that it's not an easy regimen, and it's not such a great that if you use that, you will have distinct difference between the other regimens and this. So it's not such a good one, but yes, it's also one of the regimen, and we can use this also.
Okay.
Can I come in?
Dr. Bivas is there, and he has his next talk. So I think we should welcome him, and he's somebody who can, show us more light. He is supposed to talk on a topic which I think is very close to his heart, the EGFR TKIs, and I think everything lung is very close to him. So I will request him to please, deliver his talk.
Thank you, Dr. Pathak. So very good evening to everyone, and thank you for giving me this opportunity, and thanks to AstraZeneca also. So before I going my talk, I'll just have a few words, as Dr. Tanmay said, regarding the ABCB regimen. So yes, I have not calculated the number. I think we have used almost 10-12 patients with ABCP. Out of these, I think 3 or 4 patients is post osimertinib progression in second line, and the rest in first line setting. First of all, it is not at all toxic. It's just like any chemoimmunotherapy. Adding bevacizumab doesn't cause any additional toxicity, so we don't have any problem with any of the patient ABCP as far as the toxicity is concerned. Outcome good, but again, it's 8 to 10 patient, and I think follow-up is not that great. So maybe this is on to the end of this year, we'll have a mature data on ABCP, and we are hoping that the number goes up to 20 or 25. So, but early experience is good, efficacy and tolerability wise, that I can say.
So is there like particular subset where you use it, or like?
Yeah. So first of all, one subset is that post osimertinib one. I am using if definitely the first question comes about affordability. Number one. Number two is that just a minute, I think. Number two is that any patient who has a brain mets and receipt post of RT, whole brain RT, and in that case, I am using ABCP over only chemoimmunotherapy, adenocarcinoma histology. So adenocarcinoma with brain mets post whole brain RT or any CNS directed therapy where the patient is a candidate of chemoimmunotherapy, I am using ABCP, but definitely in a fit patient, not for all patients.
So Bibhasta, one question.
Yes.
So if this is an EGFR mutated lung and post first line osimertinib, we are using this ABCP in the second line. So how is the response like? Because generally, if the patient has a driver mutation like an EGFR mutation, they generally don't do so well in immunotherapy.
That's right. So we are not using immunotherapy alone. That's the case that we are using ABCP. So chemotherapy is there, bevacizumab is there, the patient is going to respond. Now the question is, what will be the additional benefit of adding adezo? ABCP protocol did include those patients who progress on osimertinib and they had a growth. And there is a, I think 2-3 months back, there is a publication in lung cancer retrospective study, multicenter study that shows also ABCP regimen is active in post TKI progression setting. But again, it's a single arm study. I cannot call whether ABCP will have a better efficacy than chemo and BEV. But as for the trial we are using, it's the only 3 patients. Fortunately, all 3 are doing well. The well means I think 1 patient crossed almost 9 months post osimertinib. Another 2 patients, crossed almost another 1 patient crossed almost I think 8-9 months. So 3 patients only, but the experience is good so far.
Okay, nice to know that. Yeah.
Thank you. So thank you once again. So without wasting much time, I'll go back to my original topic. This is the lung cancer management, focusing on EGFR TKI. Definitely, we are obviously more focused on the advanced NSCLC. So I'll not go into the epidemiology. This has been already discussed. EGFR mutation, 60% in Asian and Far Eastern Asian. In India, the rate is around 45 to let's say 50%. In Caucasian, the EGFR positivity is 15 to 20%. And we know that the Asia contributes almost 60% of the total lung cancer burden. 70 to 80,000 new lung cancer per year in India as per the Global in 2020. A risk factor, we all know that. I'll not go details. So the genetic alteration is one of the cause that cause pathogen that acts as a driver in pathogenesis of lung cancer formations, and it's mostly we are discussing about the non-smoker. So as per the global burden of disease, there's a very good presentation, and there's a very good data on JTO published that among the non-smoker, the pollution is one of the important factor causing lung cancer. And again, those who are not exposed to that amount of pollution or non-smoker, still there's a good amount of people who do develop lung cancer. And here we found most of the molecular driver mutations or gene alterations, fusions, and one of the most common is definitely EGFR. So if you see 52% lung cancer patients were non-smoker, and among the non-smoker, pollution is one of the very important criteria. Survival is very low for advanced lung cancer. Cure is not known so far and not a term that we use in advanced lung cancer, but the way it is going with the chemoimmunotherapy or immunotherapy and the target therapy, especially in ALK, EGFR, ROS1, the 5-year survival almost crosses 50%. So whether can we call them cure? I think that is too far now, but still majority of the patient do survives 5 to 7 years in molecular diversity lung cancer when they received the target therapy. So this is we are discussing on metastatic stage 4 cancer, and in India, in our setting, almost 65 to 70% of patients do present with advanced stage, and mostly they are non-small cell lung cancer. And among the non-small cell lung cancer, I think the ratio of adenomas squamous is almost 60-40 or maybe 65-35%. So these are the different types of lung cancer as discussed. Among the non-small squamous variety, we take adenocarcinoma, large cell carcinoma. Large cell carcinoma can be large cell adenocarcinoma. There are adenosquamous carcinoma mixed variety or the sarcomatous carcinoma. These are very rare group. And we have squamous group among the non-squamous NSCLC. SCLC is a separate group, 10 to 5% and 15%. And here we do found this adenocarcinoma, large cell carcinoma, even the adenosquamous, we do found genetic alteration, mostly this EGFR ALK ROS1. Squamous cell carcinoma also may sometimes have this genetic alteration if non-smoker, young and female. So it's very important to do screen them. So these are the biomarker group. We nowadays we don't call it just non-squamous or squamous. We do term them as a molecular D1 mutation present or not. So like EGFR mutated lung cancer, be it adenosquamous or squamous or adenocarcinoma, we do call it ROS1 positive lung cancer. We don't call it NSCLC with ROS1 positivity. So these are the mostly found in adenocarcinoma: ALK, BRAF, PIK3, AKT, NRAS, ROS1, RET, KRAS, GGFR. And squamous is mostly have the FGFR amplification, EGFR amplification, PIK3, sometime made exon 14, EGFR amplification, and KRAS mutation also. Majority of these we are so far targetable. So EGFR, ALK, ROS1, BRAF, NTRK, RET, MET, and latest is the KRAS. But still, 1/3, almost 33% patient doesn't have any targetable mutation if we are discussing about the adenocarcinoma. And the story is something separate for the squamous cell carcinoma. So we know this symptom burden, they mostly present with symptomatic in diagnosis, and the symptom do depends on the site of the tumor. If it is central tumor, causes obstruction, immunity, obstruction, collapse, and breathlessness, hemoptysis. For peripheral lesion, it may develop pleural effusions, and depending on the site, an apical tumor may have superior sulcus syndrome, Horner syndrome, very pain, brachial plexopathy. Depending on the site of metastasis, patient may have symptom depending on whether it's a lung mets, bone mets, or brain mets. So it's a plethora of symptom depending on the type of disease, the aggression of the disease, age of the patient, site of metastasis, and site of the primary tumor. Site and symptoms, I'll not go into the details. So the lung cancer is it's an actual disease that leads to that needs multidisciplinary cancer management, starting from the diagnosis, the radiological staging, the pathological staging, the mediastinal staging. So each and every case, ideally, irrespective of stage, ideally should be discussing in specialty tumor board that should have at least radiation oncologist, medical oncologist, surgical oncologist, radiologist, pulmonologist, palliative care physician, the molecular pathologist, the pathologist, and also the pulmonology nurse and physiotherapist. So it's a huge group of people who has a role of active management of all lung cancer cases. And we know that the discussion and the management that is discussed in the lung cancer do improve the survival, and we have lots of publication. It is our own experience also. We have seen that the lung cancer management has been more streamlined, the compliance to the treatment has been better, the coordination and the initiation of treatment has been better, the time to treatment delay gap has been decreased, and more and more inputs we get from the other colleagues, so that supplements that improve the overall treatment plan, the treatment compliance, the outcome, and the quality of life. So it is very important to have a coordinated manner that we treat each and every lung cancer patients, because it's not just a disease. Many patients are smoker, they do have COPD. So if you don't control COPD, your lung cancer management is get hampered. So initial cell evaluation is very important, but that all suspected lung cancers, we have to have detailed physical examination, initial radiography, and the chest imaging, followed by biopsy, and then staging. Mostly why we do for just initial diagnosis, or those who have don't have signs and symptoms of metastasis, we do whole body PET CT scan for all patients of lung cancer and MRI brain. Then for early stage cancer, we need medicinal pathological staging and also need biomarker staging for biomarker reports even now for early stage lung cancer, and more so each and every patient with advanced stage lung cancer. We need a multidisciplinary team, as I discussed, with pulmonologists, medical oncologists, radiation oncologists, pathologists, radiologists, thoracic surgeon, the chest physician, the chest physiotherapist, the oncology nurses, especially in the um, thoracic oncology nurses. Then depending on the CT scan, I think that this practice varies from situation to situation, from institution to institution. Uh, Sputum cytology now is obsolete. Bronchoscopic biopsy we do for a central tumor. We do transthoracic biopsy for a peripheral tumor. And in case of any suspicious oligometastatic area, we do prove them with tissue diagnosis. Biopsy is the mainstay of diagnosis, true-cut biopsy for all lung cancer, unless it is a central lung mass where bronchoscopic biopsy, and if it's not possible, we do EBUS TBNA for central nodal, both diagnostic and pathological staging. So this is like a CT scan showing a mass with a very bulky mediastinal adenopathy. So this mass is very easily doable through transthoracic biopsy. And if there is any contraindication or the patient is not fit, sometimes we can do bronchoscopy. It is very easy to do a EBUS TBNA from those samples. MRI is very important for each and every lung cancer patients to know whether brain metastasis present or not. So with PET CT scan, each and every patient should undergo contrast enhanced MRI of the brain if unless there is a contraindication, and in those cases, CT brain with a contrast is important if the patient is not undergoing PET CT scan. Biomarker staging, patient with targetable genetic mutation has approved treatment option in advanced stage. In stage 3 cases for a local for unresectable patient with a stage 3 lung cancer where the initial plan is CTRT, definitely the biomarker doesn't have any active role as of now. But in early stage lung cancer, the development happened very fast, and we know that we need EGFR testing in patient early stage lung cancer for operable case where there is a role of adjuvant TKI. Nowadays, we have is an era of immunotherapy, and we have 2 clinical trials that shows that adjuvant IU is effective. One is atezo, one is pembrolizumab. So we need PD-L1 report also for those patients to select for adjuvant immunotherapy. And now we have data from chemo immunotherapy in early stage also. So it's very important to do biomarker testing in early stage lung cancer also. So this is the evolution, I think, as discussed from my previous speaker also. This is the evolution of chemotherapy. It's initially chemotherapy area, now is a precision medicine. The discovery of the biomarker and the research and development leads to discovery of the novel target therapy, TKI, and latest is immunotherapy. And now we are moving from the chemo immunotherapy or immunotherapy era from advanced stage, now moving towards the early stage. And we know that even stage 1 to stage 3 has a role of immunotherapy, be it neoadjuvant, adjuvant. And there's a pretty established role of constellation immunotherapy in stage 3 lung cancer after CTRT. So almost all cases of lung cancer nowadays, there is role of immunotherapy. TKI has a role both its early stage and advanced stage. EGFR mutation, we know the data. It's an activator. EGFR mutation is pivotal driver of malignancy, and in case of EGFR mutation in the transkinase domain, that the even without binding with the ligand, the receptor remains constantly active, and there's always constant cell proliferation, cell survival, angiogenesis, metastasis. This is the mutation that leads to constant activation without binding the ligand. So leads to proliferation, invasion, angiogenesis, metastasis, and inhibition of the apoptosis and the enhanced cell growth. So this is the EGFR mutation domain in exon 18 from in EGFR gene from exon 18 to exon 21. Most common, this is the tyrosine kinase domains, and we know these are the mutations. This is a P loop, this is alpha helix, this is a loop. It's more, the most common is a deletion 19 in exon 19 and the exon 21 substitution with LFA8R. But there are other mutations also like L861Q in the exon 21. We have exon 20 insertion, T790M. We have exon 18 insertion like mutation G709X. These are the uncommon mutation who are also sensitive to EGFR TKI. So these are the type of the TKI. You all know that first, second, third generation. Latest is the osimertinib, is a irreversible one. It's also active against T790M and it's the most active agent in the brain. We all know the trial data. This is the Jeftinib, the landmark IPAS trial. Then we have other NEG002. We have Alotinib data, subsequently optimal Uvetag ensure study. Then we have Afatinib data from Lux Lung 3, 6, and 7. Latest is ARCER 1050. So the first and second generation TKI till Dacomatinib, until the Dacomatinib failed to show any OS benefit, but has a very good significant PFS benefit with the increase in quality of life. There was they failed to show OS benefit because of the huge crossover. Dacomatinib is the first second generation TKI that shows PFS and OS benefit, and we have in general the PFS range between 19 to 14 months. The Archer it was 14.7 months. Then we have the latest data on osimertinib. We'll come to that. So this is the overall survival data. Brain mets was not included in the Archer study, and this is the hazard ratio as compared to the first generation TKI. Caveat with Dacomatinib that because of statistical design, we do not know how much OS difference is actually significant, because this trial did has a hierarchical alpha spending. That means the trial has a primary endpoint as a secondary endpoint. The primary endpoint is PFS. There are two secondary endpoints. First one is the ORR, second one is the OS. So what is the hierarchical statistical design? Once your primary endpoint met, you can spend the p-value, the alpha, for the secondary endpoint. So the PFS was met as a primary endpoint, so the alpha moved to the secondary endpoint. Now for a hierarchical analysis, once the first co-primary endpoint met, then you can spend the alpha for the second co-primary endpoint. Because ORR was the first co-primary endpoint, and there was no difference between overall response rate between Gefitinib and Dacomatinib, so we do not know what p-value, what alpha we can spend for the OS. That means what amount of OS difference between the standard of care at the IP, the study under drug, we can call it statistically significant. So though the Archer did show numerical statistical OS benefit, but we cannot call whether that OS benefit is statistical difference or not. But to me, this was a clinically meaningful gain in OS. So this is the Archer 1050 PFS analysis. Non-Asian done better than the Asian, some contrary, and DL90 later were also done similar. But if you come to the West, again there is not much of difference between Asian, non-Asian, and also L5 versus DL19. So this is unexplained flip between OS and PFS. I don't give too much of attention to this because these are the single study with some subgroup analysis. Tolerability profile is definitely one important. 66% patient require dose interruption, dose modification. So the AE leading to discontinuation was 9.7%. AE leading to reduction modification was 66%. Whereas in FLORA study, it was only 5%. So definitely we know that osimertinib is one of the most suitable TKI in terms of AE profile. It has the best AE profile and the least discontinuation rate. So it's an unmet need in India, but not in India, also in globally also. High burden of EGFR mutation NSLs observed in India, as I discussed, 45 to 50%. Majority of the patients do develop resistance for the currently approved TKI, and patients with brain mets still require effective treatment because it affects your survival outcome, it affects quality of life. Currently, approved EGFR TKI in first-line setting have been associated with clinically relevant toxicities and very poor CNS activity. Here comes the role of osimertinib. So, just a minute. So, osimertinib, we all know about mechanism of action. This is a least definite to the wild-type EGFR. That's a least toxicity profile. Coming to the FLORA data, we all know about the FLORA study. This is treatment-naive patient with stable brain mets, DL19 and L858R. Randomized untreated patient, randomized between osimertinib versus comparator arm, either Jeftinib or Alotinib, 1:1 randomization. PF fine. So this PFS is was primary endpoint, very statistically significant, clinically meaningful, 10.21 versus 18.9 months, hazard ratio 0.46. You see the Kaplan-Meier curve starts separating very early and persistent throughout the course. It favors all subgroup. CNS full substance analysis is the most active TKI in the brain, so definitely it has a very good CNS activity. If you see the median CNS PFS is not reached in osimertinib versus 13.9 months in gefitinib as a ratio 0.48. Statistically significant activity, both in terms of treating the CNS disease, also in terms of prevent CNS progressions. Final ways, again, significant ways benefit, 38.6 months versus 31.8 months as a ratio 0.8. And many patients did crossover from the SOC to the osimertinib upon progression and on development of T790. But still, there is always difference persists till the end. Patient remaining on study treatment and time to first subsequent treatment death definitely much higher with osimertinib as compared to comparator eye. At 36 months, patient remaining on study, even 9% on gefitinib or alotinib versus 28%. Almost 1 in 3 patients still on osimertinib and at 3 years. That is pretty good. We have also few patient long-term survival, almost 4 or 5 years now on osimertinib. Toxicity profile, did any patient had adverse event more than 20%, but very few have grade 3, grade 4 toxicity. Transaminitis, rash, acne, diarrhea, nail changes. These are the most common toxicities, and we are all familiar. So the FLORA study showed a statistically significant and clinically meaningful OS benefit of osimertinib. OS was increased in the control arm by 6.8 months. And in this study, in the control arm, if you see the median OS with gefitinib and alotinib was 31 months. If you see the TMS trial, the median OS with gefitinib arm was only 15 months. So there is some difference in terms of activity, maybe in Asian, Indian versus other Asian patients. And we are not sure how many patients in the comparator arm in the TMS trial did receive osimertinib on progression. Maybe the most of the patients in the FLORA study, when they develop progression and develop T790M, received osimertinib. So that may be one of the reasons why the outcome is that good in control arm. It is the first EGFR TKI that shows statistically significant OS benefit versus other TKI. After 3 years, 28% patients still progression-free on osimertinib arm versus 9% on comparator arm. It presented a favorable toxicity profile, no new safety signal as compared to the AURA study. So final ways analysis of the FLORA reinforce the osimertinib is the standard of care, one of the standard of care, maybe the preferred standard of care in first line setting, a patient with EGFR mutation positive advanced NSCLC, more so in patient with brain metastasis. So this is the current NCCN guidelines, almost all treatment options, first, second generation TKI and other combination also is one of the recommendation. Both Arlo, Ramesuri and Arlo Bevacizumab also is there, but osimertinib is the preferred because of the higher PFS was difference in its activity and toxicity profile. So I think I'll stop here. If there's any question, I'll be happy to answer. And I think most of the question will be discussed during the panel discussion.
Yeah, but then we want some insight.
Sure.
So like I had a very poor experience with dacometinib. So what has been your experience?
So fortunately, my experience with dacometinib is very good so far because for any patient, any day, my choice for EGFR mutant lung cancer is osimertinib. But because of the access to care, because of the cost, definitely most of the patient can't afford. So I have to choose other. We will discuss sometime maybe later. But in a brief, I have treated almost 105 patients with the dacometinib so far. The median, we have just analyzed the data. The median OS, though there is a lot of censoring because many patients already on active treatment. The median OS, we have achieved almost 25 months, median PFS 21 months. Okay. It's active in patient with CNS mets. So we have 40% patient with brain mets on dacometinib, and they do show activity in brain, both in untreated or treated patients. So our experience so far is very, very promising and very, very satisfactory with dacometinib.
Yeah, so that was something which was running in my mind because I happened to give only 3 or 4 patients with dacometinib because fortunately we had osimertinib with us. But in those 3 or 4 patients, in fact, 2 of them I had to stop. So I was always thinking it cannot be so bad. This must be an aberration. It could not have been so bad that 50%.
Maybe it's a few patients. Most of them we have in a clinical outside the. Because most of the patients received initially with compassion drugs, so we had to start on 45. But in clinics, I am starting them on 30 mg per day starting dose, and only 10% patient required reduction from 30 to 15 mg.
Okay. But otherwise you use 30 milligram.
30, most of them.
So I tried with 45, reduced it to 30. And there was a time also I reduced it to 30 on alternate days. But even then the patient did not tolerate. So finally I didn't
I
push it
feel
further.
30 starting dose may be a good starting like effort in even Indian patients.
Okay. So wonderful, I think, as always, and you have covered most of it. So now for the panel discussion, I don't think we have much to say after all that you have said, but nevertheless, we'll see how we can take it forward. So Dr. Tanmay, I hope you're there.
Yes, I am there.
Okay, and Dr. Abhishek, he's also there, I guess. Hello. Am I mistaken? Like Dr. Abhishek Upadhyay from TMC Jamshedpur.
Sir, I'm here. Good evening.
Hi. Sorry, Dr. Amitabh. I'm extremely sorry. I'm extremely sorry for that. And Dr. Upasana, you are also there. Okay. So we'll try to learn few things from all of you and see how we can proceed after, wonderful talk by our predecessors. I don't think there is much left, but just give me a second. Okay, so is my slide visible?
Yes, sir. Can you please make it full screen?
Yeah, I'll do that. Just a second. Okay, so we will discuss about EGFR mutated non-small cell lung cancer. And the case has been given to me. It's a 54-year-old male, former smoker, 20 pack years. Okay. And type 2 diabetes mellitus, ECOG PS1, suffering from pleuritic chest pain. There was some shortness of breath. And on CT scan, what they could find was a large left lobe pulmonary mass, 42 into 37 millimeter. And this is a left lobe lesion, and he has a right adrenal gland metastasis. And histology was adenocarcinoma, and diagnosis is stage 4 NSCLC. Dr. Tanmay, I just to set the ball rolling, like how many number of metastatic CA lung do you see in a month?
So see, CA lung or metastatic CA lung is one of the very common malignancies which we see, and I think in a month, 3 or 4 but at least 3 to 5 new patients of metastatic CA lung. We see generally one or two patients a week. I think these are the number of patients which I see, new patients.
Okay. And Dr. Amitabh, how are things in Jamshedpur?
Sir, almost the same, but the numbers are higher. Almost 10 cases we see new cases in a month.
Okay, so 10 cases in a month, so almost 2 new cases every week. Okay, so so this particular case which has been given to us, it has got maybe a T2 lesion in the left pulmonary mass with there is no lymph node mentioned here, and it's got a right adrenal gland metastasis. So, what would you like to do further with this, Dr. Mehta?
Sir, I think the staging is done by CT. And further brain imaging, I'm not able to find.
There's no imaging. I don't think they have done.
Yeah. So further staging workup should be completed. If not brain, at least brain MRI and bone scan should be done. If not, then PET CT.
Okay.
See the volume of, the further sites of metastasis.
So, like in your setup, are you doing PET scan for all the cases?
Sir, it depends upon the profile of the patient. If because we deal with two kinds of the patient, one is Tata Steel patients. For them everything is free. Okay. So we offer PET CT and brain MRI routinely. And for other patients on which PET CT is paid, so we routinely offer CCT chest, abdomen, bone scan, and CCT brain. So this is free for them. So we compromise a bit, but that's what we can offer to poor patients.
Very perfect. And Dr. Upasana, what's about your institute?
Sir, yes, sir. We mostly go for PET-CT and MRI brain, but if the patient already presents to us with CCT thorax, then we would try to complete the other workup by doing a CT abdomen and a bone scan. That saves a lot of time actually. So otherwise, if a patient comes upfront, so PET-CT and MRI brain, sir.
Okay, very nice. So they did a histopathology and it was adenocarcinoma and molecular panel was EGFR mutated L858R. Okay. So like what could be the options in this patient if we see just this amount of data that he has got a pulmonary lesion which is around 4.2 centimeter. We don't know the nodes, we are not aware of, and he has just got a contralateral adrenal mets. So like is there a possibility of thinking about oligometastatic disease and a cure, or do we straight away go to the systemic therapy? And so I just want to understand, like Dr. Tanmay, what would be your take?
So no, oligometastatic, yes, but I don't think we treat in this oligometastatic fashion in lung cancer. For breast or for colon, it's fine if a solitary liver mets or whatever. But
Okay.
I think in lung, it's not a good type of malignancy. So mostly I preferably plan to treat it with palliative intent only.
Fair enough. But suppose you do an MDT and you have a very aggressive surgeon and he says, I can do this lung surgery and also I can do an adrenalectomy. So how do you counteract that? Or would you like given that's a curative intent? Because from the data that we have, we don't see nodes out there. So just consider that this is the case. So like, what will be your take? Like Dr. Amitav or Dr. Upasna, I just want to see what's your, what will you?
Sir, I would be rather thrilled to have Vivash sir's opinion here since the tumor board is really very interesting. So I would really want to know whether this, in our case, I would start with palliative chemotherapy by counseling the patient that it is a stage
Okay.
4. But having said that, this looks really very thrilling because if it was a bone met, so or a single met where the disease is localized, so maybe we could have thought of radiation and then with a good quality of life. But in actual scenario, I would like to take Vivash sir's opinion.
So I think if Sir is there, I would like to have his opinion just for the sake of discussion. Is Dr. Vibhas there?
Yes, yes. Can you repeat the question?
Oh, okay. So, sir, what we were thinking about a hypothetical situation that this patient has got a 4.2 centimeter lesion in the left upper lobe, and there is no mention of any nodes or anything. And on the right adrenal, there is a single adrenal lesion. So suppose if we take it to MDT and the surgeon says, okay, I'm very confident that I can do the surgery of the lung and as well as I can do an adrenalectomy. So what would be our take?
So definitely, if the primary is resectable and single adrenal mets, I think curative intent can be taken. Number one, that was a practice even for a long time. But for the now the era has changed. If the patient has a driver mutation, what I'll do actually nowadays is that start with TKI, see how the patient is responding. That gives some prognostic significance. If the responding beautifully, maybe an interval scan after 3 months shows both PR, let's say in primary and the mets, we'll follow the same. We'll consolidate primary. If it is resectable, go for surgery. Yes, I will take a curative setting for that. But the TKI, how long will be a pseudoadjuvant or adjuvant? I don't know. Even for oligomets, if it's a driver mutation, maybe I'll continue TKI for a long time. But yes, I'll go for one chance. Yes.
Okay. So, but if the surgeon is very confident that it's a 4 centimeter very well resectable lesion and he can do an adrenalectomy, so
yeah, I know that this even the upfront surgery can be done, but I will not do that because it's a metastatic disease. I want to show how the patient is doing with therapy. If there is a good prognostic one, then probably I'll do it later, maybe after some time.
Yeah. So very nice. I think when the slides were given to me, I was wondering why they don't have any surgical option here. So I was just thinking that maybe I will discuss it out with all of us, because I think that one of the option there is in this kind of limited oligometastatic condition, maybe surgery could also be thought about. Might not be the ideal thing, but can be thought about. So now let's get to so Dr. Tanmay, suppose surgery is out. So now we come back to the case and we take it as a metastatic disease. So first line, Dr. Tanmay.
So I would prefer to use osimertinib upfront for these patients if because in that is the preferred treatment of choice, barring aside the finances if it's not an issue.
So we all have seen enough data to support that osimertinib is the drug of choice. Now, Dr. Upasana, now does this L858R, somehow, pushes you to think something more, or is it okay? Like even if it's an L858R, you go ahead with osimertinib, or do you still think that there is some role of, maybe even erlotinib and bevacizumab? So do you think?
Yes, sir. Actually, to be very frank, the patient is very young, so rather 54-year-old. So if the same patient came and he or she was 70-year-old, or so I would obviously try out the first generation TKIs as well. And mostly we start patients upfront with chemotherapy because of logistics. And then this report that takes some time. So if I'm upfront available with the EGFR mutation status, so then it's a different issue, as Dr. Tanmay Mandal has rightly pointed out with the data we have. Otherwise, what we go ahead is with first chemotherapy, and then maybe we would continue TKI. And yes, I would, because of this common mutation and patients who have been doing well with erlotinib, geftinib, so I may think of giving a first generation TKI if the patient is elderly enough.
No, first generation TKI with chemotherapy or first generation TKI with bevacizumab?
No. After finishing off chemotherapy and assessing response, and then we can put on to the TKIs.
So, Dr. Amitabh, what would you have preferred?
Sir, answer is very similar. As per the academic data, it's osimertinib, but practically most of us will be giving this first generation TKIs only depending on the patient's finances. And obviously, all of us start with chemotherapy as long as reports are not available. And the moment reports becomes actionable and available, we switch over to TKI.
Now, like suppose if there is a patient who is not so symptomatic and he has come first time with you with, like, are you in a hurry to start a chemotherapy, or like, are you okay if turn around time of 7 days?
Actually, sir, we are not in a hurry if the patient is not symptomatic, but most of the time it's very difficult to counsel the patient family.
Okay.
Because they have the diagnosis of carcinoma lung, which is stage 4. So it's very difficult to stop them for another 10 days or 2 weeks before starting treatment.
So have to start.
Yeah.
And then you complete the entire chemotherapy? Or
No, sir. We'll stop just after 1 or 2 weekly doses.
Okay.
So may I come in?
Yeah, please, sir.
Yeah. So I think in today's time, single agent first generation TKI is the suboptimal treatment. So even if the patient is not affordable, you can give chemo plus TKI. That is not that costly. But single agent TKI, first generation TKI, probably no in 2023.
Yes, sir. Even I also feel so, but depending upon the environment that you work in, that could push things many times.
Chemo and the pemetrexed followed by chemotherapy and Jeptin is too cheap. Jeptin is 2000 only.
Okay. So point very well taken. So definitely this we all know that osimertinib should be the standard of care. So another very important question, what are we looking at? Efficacy, safety, quality of life, or OS? Dr. Tanmay?
So all of them, especially of course the overall survival, that is what we all look at. That's the most important thing. And the second, if you ask me, yes, the quality of life and the safety also.
Correct. In a way, I think all of them are, we would like everything to be there. But definitely, if we are looking at one particular aspect, quality of life is a very, very important. Okay. So that has already been discussed by Dr. Vivas, what's the advantage of using an osimertinib. So we'll not go ahead with the same thing. So next. Yeah, so this was something. In fact, will type of mutation change your choice for EGFR TKI? Sir, the Vivas sir, since you are there, if you can throw some light on this.
So what I can say that the molecular structure of the drug binding site of exon 21, LHR and the DNA is slightly different. So whatever drug you give, the binding is different, the efficacy is slightly different. That means there is no particular agent that will be better for exon 21 versus some other drug. The binding is different, and that is true for all drugs. So as of now, we don't have any large scale data that support that this particular agent is better for this mutation. And as of today, I don't do customized treatment depending on the type of the mutation between DEL19. Definitely, we are not discussing about uncommon mutation. But between DEL19 and LHR, as of today, I am not customizing my treatment.
So yeah, so I think that's what even the data says. Like though the difference is there, but it is not so significant that we do not choose osimertinib in L858R. So definitely, even in L858R, it remains to be the standard of care.
Sir, I have a doubt. Can I ask Sir Vivas sir if it's feasible?
Yes.
Sir, actually, I got a protocol for a 60-year-old patient. She has got no brain mets, but she has been put on erlotinib and bevacizumab post pemetrexed chemotherapy. So, what is your take on that particular? Yes, sir. It is a common mutation. I think it was L858R or deletion 19.
No, it's an option. It's a Bevarlo is also an option, no doubt. What I mean to say, among the 5 options, you cannot say that this option is better for this mutation. All are options. You can choose anything, what you choose. But definitely, Oswant will be the first choice, followed by other options. We sometimes use Bevarlo because of many logistics reason, but I am not saying that Bevarlo will be better than dacometinib or let's say osimertinib.
Okay, sir.
But it's a good option.
Thank you, sir.
Good. So this we have already killed. So we will go ahead with osimertinib because it has shown to be effective in both the mutations. Okay. So overall response, even this we have, sir has already explained what's the advantage in all those Lux, Lung 7 and Archer, and why that he has very well explained why we are not taking the, the advantages of the outcomes from the Archer 1050. So that has already been discussed. So how important is overall survival for picking up EGFR TKI for your stage 4 NSCLC? Dr. Amitabh?
Sir, obviously this is a gold standard across all the cancers, overall survival. But so we all are aware that it's very difficult to achieve overall survival nowadays in the era of targeted therapy, in which almost all the trials there is good amount of overlap, almost 60-70% overlap. So yeah, this is important, but I will take this with a pinch of salt.
Okay. No, fairly correct. So yeah, we'll go ahead with that. And this we have already seen that even after 3 years, there have been a good advantage of using osimertinib. So this has already been discussed. So we will now, while choosing EGFR TKI, can you ignore the risk of developing METs in your advanced EGFR metastatic non-small cell lung cancer? So this is I think one of the very important. So Dr. Upasna.
Baseline scan we already do. So if at the baseline we don't have brain mets, then as Bivas sir has like already enlightened us, so we can go ahead with the other second generation TKIs. The dacometinib has scored very well if the patient is upfront metastatic but has MRI brain within normal limit. So, and if the patient is responding well, then mostly it is very unlikely that the patient will develop brain mets, though there is a considerable chance of developing brain mets. So keeping that in mind, we can use the other TKIs as well, but obviously osimertinib scores well if we have to keep in mind the CNS penetration benefit that we can achieve.
So it does prevent from, further CNS metastasis. So the most advantage, I think, of osimertinib lies there, that even when future chances of CNS mets can also be prevented. So do you routinely do MRI? I think we have already discussed that. Dr. Upasna, you are doing it upfront, and I think even in our centers, we are doing an MRI brain. So even if patient has no CNS complaints, so definitely we are doing it. So this seems to be an interesting question. So will you miss asymptomatic CNS mets if you do not do routine brain screening at the baseline? And what are the implications of missing those CNS mets? So Dr. Tanmay? Dr. Amitabh, maybe you can take it.
Sir, since we all are doing this, but it's very unlikely that we will miss this brain metastasis. But still, yeah, it's a hypothetical question. Then definitely there are implications. If you are treating with either chemotherapy or first generation, second generation TKIs, there are the increased chances of not having any response in the CNS response versus the treatment with the third generation TKI, in which there is very good CNS response. So that is the implication, likely implication.
Okay, yeah, that's very important. So as we have seen, we are supposed to do MRI brain. That is an ideal, but definitely depending on the constraints that we work in, but definitely a brain imaging needs to be done. So the efficacy wise, Lux, Lung and Flora trials included CNS mets patient, but they were excluded in Archer patient, which is a very, very important factor in metastatic CA lung. Inclusion and exclusion of brain metastasis remains to be a very, very, predictive and a prognostic thing. So I think that's where the Archer study, fares slightly lower than what we have from the outcomes of Flora trial. So intracranial or CNS responses were not assessed in Lux Lung 3, 6, or 7. And patients with brain metastasis were excluded from Archer 1050 trial. So this is a very, very important point that needs to be highlighted. And herein we have both systemic and CNS clinical benefit of patients who are getting osimertinib. So yeah, this is interesting. Like we had already discussed a part of it. Would PD-L1 positivity favor in starting IO in this patient? So, Dr. Upasna?
Yeah, this has already been very discussed, but in our clinical practice, I have not yet started patients, or mostly we don't pay much attention to the PD-L1 positivity if the patient is EGFR positive. So we go ahead with the normal treatment strategy. So no, we don't favor IO in this particular case.
Okay, Dr. Vivas, if you are there, like we can come back to our basic question. So suppose if a patient has progressed on osimertinib, do you do a re-biopsy or something? Or like how do you go about it? Hello? There's a call coming, just a second, just a second. Hello? Good evening. I'll give you a call. I'm in between something. I'll give you a call. Yeah. So I think, Dr. Tanmay, what would be your take?
So yes, if a patient has progressed, we do a rebiopsy. First of all, we do a rebiopsy to see whether there is any transformation or not, because we see small cell transformation in some patients. That's one thing. And also we repeat at least the NGS, at least even if not possible, we do a T790M mutation status on the rebiopsy specimen to see for secondary resistance to T790. These are at least the two things for which a rebiopsy should be done.
But if the patient was already on osimertinib, do you still want to do T790 mutation?
At least for prognostic purpose, even if the patient is already
okay.
Treatment sake, I would always prefer doing a T790 in almost all patients and a rebiopsy also.
Okay. So there is definite data that if you have EGFR positivity, then your IOs generally do not work much. And secondary, there is also a concept that these patients tend to have more of pneumonitis and ILD in case if you use IOs after the osimertinib. So that's an important point. So what about the safety profile of EGFR TKIs? I think we all have seen that it's relatively a safe drug and very well tolerated. We all have used it enough, and we are very convinced that it has got very less of side effects and very well tolerable drug. So amongst EGFR, I think it is one of the best tolerable drug that we have. And this is what the data comes from most of the important trials, but also what is there from our experience. So definitely we do know that osimertinib is very well tolerated. So does quality of life matters? I think has already been discussed. It definitely matters. And in today's world, it matters a lot. When we have a lot of options, I think quality of life is one of the most important thing. And herein we see that the trial shows that the quality of life is also very good in case we use osimertinib. So from the Archer trial and Flora trial, what was the outcome here was global quality of life was maintained in dacometinib group and was significantly improved, but not considered as clinically meaningful. But I think more than these trials, I think it's our day-to-day working and the concept that we develop about the tolerability of drug that is more important than what the trials say. So when would you consider sequencing approach, Dr. Amitabh?
It's a very difficult question, but because osimertinib is the standard as per the literature, and sequencing, only reason I will choose is financial, no other reason. Okay. If the patient is not having any money at present and wants to have that higher molecule at a later date.
Correct. Yeah, that could be very ideal. So what about this, the outcomes from geotag trial, and which says that you use first a second generation and then followed by osimertinib on progression. So what your take on that?
Sir, again, it's how many percentage of the patients are able to take the second line treatment. That is very important in any of these crossover studies, because the best chance to treat is the first line only.
Right. So this is what is being highlighted here. The best thing is to treat upfront and be aggressive, because maybe very 1/3 of the patient you might not be able to treat, even if they have the progression. So the ideal thing is to go ahead and treat maximum number of patients with the best drug possible. Definitely financial consideration needs to be taken into account. So this was the geotag, which we were thinking about the sequencing. However, there were a lot of flaws, and statistically they were not very convincing. So we do all agree that the best drug to be treated upfront, and that should be the way we should go forward. So the conclusion remains to be that osimertinib has definitely shown a lot of significant improvement in PFS over standard of care, being the first generation TKIs. And it is a very good drug which has very good CNS penetrability, and therefore it prevents a lot of CNS mets, and it has shown to be having a good quality of life, and a lot of people continue to be on this treatment. And the toxicity profile is also very, very favorable, except the financial toxicity. So I think with this, we had a wonderful discussion, and a lot of our doubts were cleared. So if there are anything else we can discuss.
Sir, another last question. I just thought I did not get into the in the middle of the discussion last what we were discussing, the ABCP versus. I just wanted to have an idea regarding all of your experience regarding docetaxel and ramucirumab. So if that can be highlighted, because mostly this is more approachable kind of a treatment post progression with osimertinib. But if I don't have much of experience, because the patient who progressed with osimertinib did very bad, and she could not survive to take a minimum of 3 cycles of dosi plus ramucirumab. So if if you all of you, sir, could share your experience regarding this combination as well.
You see, luckily, in my case, I have treated 9 patients with osimertinib, and we got that drug only around 2.5 years back in our hospital. So till now, I'm very happy that we haven't seen any progression on that. But if you like, if there is a case, I would in fact think about maybe first doing a rebiopsy, and if there is a tissue available, or maybe even a circulating tumor DNA test, get an NGS done, and look at because post osimertinib we do say some kind of MET insertions, so those are common, or maybe even the histopathology also changes many a times. But in case if no such things happen, I would still try to give a ramucirumab based therapy. But one thing which is debatable, but I would like to do is like, if there is no financial toxicity, probably if the patient hasn't got any brain mets, I'll try to continue osimertinib. So that with an idea that to prevent any further, brain mets, if it's available, and that thing. So ramucirumab with docetaxel plus osimertinib, if tolerability, could be very well tried. Yeah.
Thank you so much, sir. Thank you.
Sir, I have one question, if you permit. So actually, I have a patient very CA lung case since last almost 5 years. He was exon 19, del 19 positive, and he was started on first generation TKI in Delhi. And he received this TKI for almost 1.5 years, and subsequently he progressed. So post gefitinib, he started on erlotinib plus bevacizumab. So that he continued for another 6 to 8 months. Subsequently, he received 2 more lines of chemotherapy on progression. And finally, his T790M mutation was negative. So my question is, any role of osimertinib after this first generation TKIs and 2-3 lines of chemotherapy, despite this T790M being negative?
Yes, it's not just T790. I think there are other mutations also. But like, just to recapitulate, he has received a geftinib, and he has received
erlotinib and 2 more lines of chemotherapy.
Cytotoxic chemotherapy only. Huh?
Yeah.
I think there is still a chance of giving him, like if financial constraints are not there, I think progression on only first line, I think there is a role of using a second line. In fact, I would rather prefer afatinib or dacomitinib at this point of time. And then that would be a major choice, because his T790 mutation is negative. So there could be some other uncommon mutations which are better handled by second generation TKI. So I would like to give him a second generation TKI rather than osimertinib at this point.
Yeah, but yeah, you're right. So since he was started on osimertinib despite T790M being negative, and he's doing well since another 2 years. So then, surprisingly, he's still on osimertinib, which was given at the last kind of trial basis. So
correct. So there could be some other mutations which were, they were acted upon by osimertinib. But if you see, if you go by text, I think definitely osimertinib does also act more on, the conventional and non-conventional mutations. But second generations could also be used in T790 mutation negative patients. So they take care of those uncommon mutations. So that was also an option. Yes.
Thank you for the inputs.
Thank you. I think with this, we should conclude a session. It has already been, it's almost 9 o'clock. So I would hand over to the organizers, and I think this was amazing learning. And thank you all of you. And over to the organizers. Yeah.
Thank you, sir. Thank you for joining.
Thank you.